This is a case example of a Buckethandle meniscus tear. The meniscus and the cartilage within the knee fit together, kind of like a puzzle. An MRI is the best way to see that puzzle all together. As you can see, the end of the femur bone becoming cartilage, the meniscus tissue in between the next layer of cartilage on the tibia and the tibia bone. And how these pieces fit together are most normally associated with physiologic loading of the joint in the normal case of the knee joint. The joint is an organ, and normally these structures balance physiologic forces during normal activities as well as sports. This allows for homeostasis of the joint, or balance of proteins that are normal within the joint fluid to maintain normal joint function. At times, with injury, we lose some meniscus. When we lose pieces of this puzzle, the forces across the joint are abnormal, and we have changes in their shape, and this leads to changes in the balance of proteins within the fluid, and ultimately joint disease. So homeostasis is what we normally have within the joint, and this is an arthroscopic view inside of a knee joint that is balanced. The structures are normal, and we have an appropriate biomechanical load, leading to the normal volume of joint fluid, painless motion, and a balance of both anabolic and catabolic enzymes. However, when there is injury, you have abnormal biomechanical loads. You'll have episodes of swelling. The fluid at time will be abnormal. It'll lead to painful motion, and then an imbalance in the proteins within the knee with an upregulation of catabolic enzymes, which can be detrimental to the joint. With these injuries, they can occur in two scenarios: acute injury event or within repetitive overloading. At times with acute injury events involving meniscus and ligament injuries. Repetitive overloading at other times causes accumulation of change that occurs with time. It can sometimes be associated with certain activities. Repetitive overloading, at times we know there's a higher incidence in athletes. Sometimes athletes are aware of this and sometimes they are not. There's also a higher incidence with people whose body mass index is over 30 or with higher weight. Also, we know there's higher incidence in certain positions and activities, and also more common in people with abnormal shape of their bones, such as being a little bit bow-legged or knock-kneed. Not all cartilage or meniscus injuries progress. Management at times involves non-operative management, meaning at times we can rehabilitate individuals without the need for surgery. Other times surgery is indicated. Initially, when we're trying to manage someone without surgery, we initially manage that inflammatory or that swelling response to any change within the knee. Sometimes injection therapies have a role for this. We also at times can utilize braces or other things to take away deforming forces that are encountered along the way, whether it be injury or abnormal shapes of bones. We then rehabilitate and attempt to return our athletes back to their activities. Operative injuries, we always consider the deforming force. That is, if people are a little bit knock-kneed or bow-legged, we always make sure we have a full quiver of options in terms of our surgical abilities. We then rehabilitate them and look to return these athletes back to their activities. This is a case example of a Buckethandle meniscus tear. The meniscus is seen here in the middle of this arthroscopic view, and its normal location is to the right, so it is abnormally displaced into the intercondylar notch. So what you're seeing here is a meniscus out of its normal position to the right that is stuck within the intercondylar notch. So this is what we deem a Buckethandle meniscus tear, because it's like the lid on a bucket that's flopped out of its normal position. Our first order of business is with this meniscus rasp. You'll see it looks like the end of a rasp. It is diamond studded, and we're performing what we call synovial abrasion, just creating a nice bleeding bed of bone for the meniscus to repair and heal to. Then we reduce the meniscus back into its normal position. Here in this video, you'll notice that the meniscus is now to the right side of the screen, where it was to the left side of the screen. So we've pushed it back into its normal position, kind of like flipping over the lid of a bucket from one side to the other. Once we get into a position, we then suture it into place. We can use all inside suture repair mechanisms in the back of the knee towards the body. We also can use sutures that are passed from the inside to the outside, or vice versa, from the outside to the inside. So in this video on the left, you're seeing us shuttle in a suture utilizing a device, and then we're shuttling in the end of the suture as well. And that compresses and provides what we call a vertical mattress stitch to the top right. We then can perform this on the undersurface of the meniscus. We utilize multiple techniques in multiple scenarios to shuttle in sutures, and then once we have those sutures shuttled into place, you'll see that it pulls the meniscus back to its normal and anatomic position, reducing it to where it normally does live. So this process can involve sutures passed in a normal different various ways, and we also tend to use a whole lot of sutures in these cases to make sure that we have a strong repair of the meniscus to its normal location. After we complete the repair, we many times poke holes from the bone marrow into the knee, which creates bleeding access of bone marrow into the knee joint, which aids in the healing process after the repair. The video to the right, you'll notice that bone marrow is starting to creep into the knee and pulsating with the pulsations of the heart, showing that we have excellent marrow access to aid in healing of the meniscus. Hope you've enjoyed this case example, and I hope it helps prepare you either for a surgery that you may have upcoming or helps you in your rehabilitation phase.